Good afternoon, everybody, and welcome to this Wellbeing of Women monthly webinar. We're going to talk today about menopause and hormone replacement therapy, commonly known as HRT, and we've entitled our webinar Fact and Fiction. Because despite being a key treatment option for perimenopause and menopause, we know that less than 1 in 5 women of menopausal age are on hormone replacement therapy, and that amongst Black women and Asian women, this figure is much, much lower. So in this webinar, I've been joined by menopause expert, Dr. Sue Mann, and menopause advocate, Madhu Kapoor, and we're going to take a deep dive into HRT. And we're going to talk about some of the common and the lesser known symptoms of menopause, and we're going to explore how and why HRT is an effective treatment for some women, and consider the pros and cons of different types of HRT. So prepare yourselves, because we're going to have a feast here. And we're also going to look at the risks associated with HRT. And that's where I really want us to sort out the fact from the fiction, so that you, our audience on this Wellbeing of Women webinar, feel empowered and in control of the facts and the information you need, so that you can help yourselves and you can go along to your healthcare professionals and tell them what it is you need and what it is you would like to have. And you can make really informed decisions about your treatment options. Now, if you've got a question for one of our speakers, please email events@wellbeingofwomen.org.uk. A lot of you have done that already, and you can put your questions in the chat as well. I will be trying to monitor the chat towards the end, but I tend to concentrate on what our wonderful speakers are saying. So I might not be able to do that right until the end. And the Wellbeing of Women behind the scenes team will also be flagging up to me some of the questions if they are being repeated regularly. So we'll try to take the most common questions and address those in our question time. And we usually keep the transcript, and we're very happy to send you recordings of what's happened so that you can go back and look at it, and also responses to some of the more technical questions if you would like to submit them to us. We will get back to you. Perhaps by the end of the week. It's Wednesday today, isn't it? Yes. So hopefully by the end of the week. But the recording will be available on YouTube via the Wellbeing of Women website tomorrow. So with that, I'm going to say welcome to everybody. I'm really, really pleased that we've got these two fabulous women here today who are going to tell us firstly about lived experience. It's Madhu Kapoor, and then Sue Mann, who I will introduce shortly, is also going to help us, and she really is an expert in her field. So in a moment, I'm going to start off, and I'm going to ask both Sue and Madhu to introduce themselves, and then we're going to talk about, we're going to thank our sponsors, the Financial Services Compensation Scheme and Bolt, Bird and Kemp, for hosting this webinar and allowing us to hold it. We've now got 170 participants, and the numbers are going up in front of me. I think we've got 500 registered, and sometimes we even outsource more than we've actually registered. So Lena will keep count of that. And thank you again for everyone for joining us. And I hope that you make a regular appointment in your diaries to attend these monthly Wellbeing of Women webinars. So let me start firstly with Sue Mann, Dr. Sue Mann, who is a specialist gynecologist. And I've also wanted to say that I think this is the first time that we've been on a public platform together since Sue started as the first ever National Clinical Director for Women's Health. And some of the audience won't be surprised to hear that there is blood on the floor for how much we worked to get that appointment organised, ratified, and then advertised, interviewed, and she's now up and running. And I'm thrilled to have her here. She leads the City and Hackney Menopause Service, and she's a trainer for many other people in menopause care. And she has been an enormous source of support to me in my last 2 years as the Women's Health Ambassador for England. And of course, as you can see in my role as Chair of Wellbeing, she's here and she's in her clinic, as you can see from the platform, but she's carved out the time to do this 1 hour webinar. So Sue, thank you very much indeed. And as I mentioned earlier, Madhu Kapoor has come to us as the lived experience, and we like to get these webinars so that we have experts and or one or two or more women who've had the particular problem that we're addressing. And if it's a contentious problem, we get people for the for and the against, but we didn't think we needed that today. But Madhu has had a very challenging personal experience of menopause and trying to access HRT. And she's founded M for Menopause, which I think you can see from the lovely, calm, cool, beautiful color green in the background. And she's going to tell us all about the work that she does there and her own personal experience. So let's start with that, shall we? Sue, is there anything else that you'd like to add before I go on about your introduction, or Madhu? And then we'll ask Madhu to tell us her story from, I think, what we could say is a unique perspective of someone with lived experience. And I know that both of you will do a fabulous job. Sue, is there anything you wanted to add before we go on?
No, really, just to say hello, everybody, and welcome. Really pleased to be here. Really looking forward to our conversations this afternoon. I really enjoy this kind of session, and a great pleasure to be sharing a platform, Leslie and Madhu. So, yes, over to you, Madhu.
Please, the floor is yours, so to speak, or the platform is.
All I just want to say is I feel honoured to actually be part on a panel with Dr. Sue Mann and with Professor Dame Leslie Regan. It's an honour to actually meet you both and, you know, and get my story across. And I'm passionate about advocating and making sure that change is actually happening and we reach those communities that we need to, and also make sure that representation is important when we're actually talking about menopause. So thank you.
Yes. And I think there's such a heartfelt comment as well about the communities we need to get to. And one of the things that I think that Sue and I have managed to achieve in NHS England and the DHSC now is that we have banned the words difficult to reach. There are no women who are difficult to reach, but there are some women who it's very easy to ignore. And so we're not going to do that anymore. So, Madhu, can I turn to you now? Tell us a little bit about how the menopause affected you and your life and the sort of symptoms that you experienced. And let's start off with that.
Okay. So basically, I just wanted to start off with what I thought menopause was. Basically, the expectation was that I would just have a few hot flushes and my periods would stop one day, and I was actually looking forward to that day. But unfortunately for me, it didn't work that way. You know, I always thought I'd be able to multitask, be able to sort of, if I had issues at home when I was at work, to separate all those issues that I probably had and still be able to carry on and perform as normal. However, sort of in my early 40s, being comfortable and confident the fact that the 40s was going to be a great milestone time for me, because my daughters were much older, so they didn't really need me. So it was my time to sort of, I guess, flourish in my career, have opportunities to apply for positions, probably do some training. And socially, I had a good life as well. And then it was sort of building or rekindling my relationship up with my husband before I actually got married. So that's what I was expecting my 40s to be. And then you know, it was sort of I sort of started to change very slowly, and it began, my health was changing, but I didn't know what was happening. And basically, it affected every area of my life, but it was very slowly. So at home, how it actually happened was, you know, as I said, I was trying to rebuild my relationship with my husband because I was always sort of focusing on my children, and it was less time for us. So it was sort of going out dating, just doing things that we were doing pre us having children and everything. And then I just started to notice sort of subtle changes that were happening psychologically as well as physically as well. I was becoming irritable, very tearful, but distancing from my husband at the same time. And we were arguing a lot more. And I was ready to always fight. And I'd sort of, my character had started to change basically. That impacted our relationship. I changed from being a caring wife and a mother to actually a withdrawn individual. And actually I was expecting for my family to be there for me, because I was always there for them and I would always know when they needed me or if they needed my help and everything, but it wasn't happening to me. The type of experience that I faced was irritability, mood swings, brittle nails, dry and itchy skin, and started to have a lot of other issues, but that impacted my work life. So pre-menopause, I was an independent, confident, and proactive individual that was respected in my role. I worked with the government department for 23 years. And in my mid 40s, sorry, my symptoms sort of worsened. I didn't know what was happening. That independent individual that I was began to change. I was actually needing reassurance. My confidence just plummeted, and I just didn't know what was happening. The role that I was in it was second nature to me, attending meetings, doing presentations, holding workshops. Everything was second nature. So I thought in my 40s, my career, it would be perfect in that sense. But what began to happen was that meetings became a burden because I had brain fog. I didn't know what brain fog was. It was not being able to think straight, not absorbing the information or questions that were asked to me, and not even being able to form a question, basically, if I had any questions that I wanted to say, and sort of becoming very forgetful. And then if I was attending my team meetings just with our teams, if someone said anything, I would become very tearful, and I wasn't that type of individual that would take things personally. Obviously, as I said, my character was changing, but no one sort of realized what was that I might have needed support or reassurance. And I was actually seeking for reassurance. As I said, I had brain fog there, forgetfulness, anxiety, migraines that I was having was 2 to 3 times in a week, and it would last for a while, which meant that impacted me at work. I had night sweats, insomnia, which were consistent. It wasn't just sort of one night in a week, it was every single night. Had incontinence, joint pain, heart palpitations. In my productivity was suffering, but I still had to carry on, because to everyone I just looked normal. And then the third part of my life was my social life. I began to isolate myself, doubting my friendships, just didn't want to be around anyone, and was just withdrawn from the social activities. But I'm the one that isolated myself, but I felt alone because of everything that was happening with me, and I just wasn't coping with my symptoms. Basically, my life became dominated by my health with the symptoms that I was actually having. I just felt as though my anxiety, which I didn't even know what anxiety was, really impacted my health completely. My mental health was changing. I just felt as though I was going insane, in becoming a hypochondriac, in visiting my GP regularly, but not getting the answers that I sort of needed, even though I was getting tests done on a regular basis, but nothing would come back and no conversations were happening. In my 50s, so it was in my mid 40s that all of these symptoms happened. But in my 50s, which was in 2016, I resigned abruptly from my job because I did seek help from my manager, but not saying that I was going through the menopause, but telling her what symptoms I was sort of having, but not managing, because I didn't know I was going through the menopause, even though was thinking I was. Every time I had a conversation with my GP, there was no conversation happening that these symptoms could be linked to the menopause. And I ended up resigning from work, thinking that my health would improve and that my home life would be much better, and hoping that my life wouldn't be impacted in that way with my relationship with my husband.
And so what did your GP say to you, Madhu?
She didn't. So if I'd asked the question, it was at the menopause. So because it was in the early 40s, I started to have tests done. And it was a blood test that you actually have done when it's the 3 days of your period sort of starting, but the results would come back saying that there was nothing there. So there was no conversation sort of saying to me that my symptoms could be linked to the menopause. It was just going through all the separate tests that I needed to go through. It was more that I was having rather than conversations.
And I think that's an important point, because I think Sue will probably pick up on this a bit later, but I think it's really important that we don't formulate our diagnoses on the results of investigations and blood tests, because actually you, the person, the individual, you need your symptoms treated. And I frequently tell women I'm not going to bother taking blood tests because their symptoms are so, if you like, predictably pathognomonic. I mean, the commonest comment I say, and then when she's telling me about this, that, and the other, and then I say, and how's your sleep? And usually this woman will look really across the desk and say, how did you know? Oh, well, because I can remember how awful it was. And I really, really empathize with you when you said about irritable and angry with the kids. I remember one of my daughters saying to me, telling me something, and I said, well, why did you say that? Because I know that's not true. And she said, well, Mummy, she said, you're so frightening at the moment. She said, I couldn't possibly tell you what really happened. And there was I, a reproductive endocrinologist and a gynecologist of years and years, and my little girl was telling me this. I mean, wake up.
I would have my daughters running up the stairs because they just didn't know how to handle me.
Yes,
and
exactly.
then there'd be times they'd be telling me stories, and then all of a sudden they'd be telling me stories and they weren't sad or anything like that, or it would just impact me. I'd be crying, then they're looking at me and saying, are those sad tears or they're happy tears? I go, no, they're happy tears, but I'm crying. And I don't know why. Obviously something's impacted me, or sort of affected me in that way. But yeah.
So what would you told us a bit about the barriers to accessing help? Did HRT make a difference, and how did you persuade your GP to give it to you?
So
perhaps you didn't. Perhaps you went another route.
So one thing that I just wanted to say that, I just saw myself as a woman that was going through health issues. I didn't see myself as a South Asian woman. And I actually think that my upbringing, no matter how advanced or spoken I was, in the sense of regarding work and everything, but when it came to my health, I was very shy, not shy about it. I wouldn't talk about it, not at work. At home, I didn't talk about it because of the upbringing that we've sort of had. So, so regarding HRT, I just think that we talk about that there's not a menopause word in the South Asian language. So we actually literally silently grow up just thinking that we're going through these symptoms and we just need to carry on. That's how we've actually been brought up, to just carry on and get on with it and not have these conversations. And then the other part of it was that regarding HRT, I did have an idea about HRT, but it was because of other people's opinions. So I would listen to everybody else's opinions, but not do my own research regarding the two reports that actually happened in 2002, which was a Women's Health Initiative, and then the one which was the Million Woman Study in 2003. And I just went on people's opinions. So internally, I decided I would never go on HRT because I wouldn't need it. I'd be able to cope with life. But it wasn't that. So I would say the struggles for me was basically, I was going to my GP to ask for help. And even though I wasn't saying I need help, I'd be going talking about my symptoms, but I couldn't get across what I wanted to actually physically say. And for me, the initial barrier was basically getting an appointment with the GP was definitely a barrier, in having a conversation with reception, in the sense of telling them why it is I want to see my GP. But when you would go to your appointment, you'd be told that you can only talk about one symptom at a time because we've only got 10 minutes. I had a list full of symptoms that I was going through, and I just felt like I was being told off by a head teacher. And I was in my mid-40s and I couldn't challenge my GP because I just didn't want to be judged, because South Asian, we're told not to confront, to stay silent. And I think that's actually come up, I've grown up in that way, and it's actually respecting authority, respecting your elders. It's all of that, and that's how some of us have been brought up.
And so I'm going to interject here. How did the HRT make a difference?
So eventually I did get HRT. It's basically, I had to fight for it with my GP. She wasn't going to give it to me because she gave me her personal opinion that, oh, I think you should go on herbal medication. So I did go on that for 3 months, but I think I was so far gone, I became desperate to actually be fixed, as the word is, because I just wanted to be me again, find myself again. So I went to a different GP who was a locum, and I cried in front of her and broke down and said, I need HRT. And that's what actually sort of happened. And it actually changed my life for the better, in the sense that, you know, I got my life back. I got my home life back, in the sense of the relationship sort of building up again. But there were things that I had to work at the same time. And actually, I'm here today talking about my journey, menopause. I advocate about menopause. I'm writing a book recently about menopause, and I'm back. I wasn't that individual. I lost all that confidence. My aches and pains stopped. I ended up sleeping. Night sweats had stopped. It gave me a bit of me back and my mojo, which I wanted desperately. That's how I say it would.
Thank you so much. And I really do appreciate you being so candid with us and sharing with us. I mean, you've obviously got a lot of empathetic ladies on the thing, because they're popping in things about, yes, well, that happened to me too. So I'm now going to turn to Dr. Sue Mann, who's our menopause expert. And Sue's going to start off by telling us what perimenopause and menopause are, and actually what happens, in simple terms, what happens to all those hormones that we're hearing about. And I think you've got slides, haven't you, Sue?
Yeah, I have. So thanks, Leslie, and thanks, Madhu, because I think you touched on so many of the important parts of the experience. So you've talked about symptoms, you've talked about how long that it can go on, how difficult it is to get diagnosed. Hopefully, if learning a bit about these kinds of things will help support people on the call to then go to their GP and say, this is what's happening to me. So I'm going to just do a very few slides, because I think it might help a little bit to capture some of the issues that you've talked about. So let me just try and get my slideshow, just 2 seconds. Okay, so I just wanted to start off by talking about what is the actual menopause. It's not a very helpful term, the menopause, because the menopause is the last period that you ever have. We only know when we've had a last period when you get a year down the line and you go, oh, that must have been my last period. And by that point, all these kinds of things are, it's a bit late to start thinking about all these things. So I really wanted to use this slide to sort of illustrate a little bit about what we're thinking about. So there are various stages. So I like to divide them into premenopause, perimenopause, menopause, and postmenopause. And often during the perimenopause is the time leading up to the menopause when you might start experiencing symptoms. So this period of time can go on for any length of time. Sometimes it's very short, sometimes people don't notice it at all, and sometimes it's very drawn out. And similarly, the range of symptoms that you get are really, really variable. So Madhu describes something as really quite debilitating. It's a very common set of symptoms that I hear about. You might not have that experience. You might find that you sort of breeze through it. It's just really a matter of luck. Often the clue is in the periods, so the periods change. So you have a period of time where your periods might get less regular, so you might have them intermittently, and they might come every 3 or 4 months or something like that. Sometimes they change in nature, so they get a lot heavier. Sometimes you have a long gap and you get a very heavy one. So all sorts of sort of things, but you might notice your periods start to change. And then, you know, there's a whole catalogue of symptoms. There are some very common ones. So the hot flashes, the sleep disturbance, the night sweats. I think, Madhu, you described very nicely some of the sort of mood symptoms. I mean, I often hear women sort of saying, I don't really feel myself. I used to be very confident about doing these things. I don't feel that anymore. I don't understand it. Often people complain of loss of libido, and all this is sort of coincident with the hormones they're sort of all over the place, if I'm honest. So you've got a whole lot of hormones there. The main thing is estrogen is decreasing gradually, but it's not sort of as low as it will be once your periods stop and into the post-menopause. So the symptoms are slightly different, and the symptoms tend to be time limited. So, you know, the night sweats and the hot flashes, they do tend to disappear of their own accord, whatever you do. There are some symptoms that tend to carry on, and they're more likely to be the low estrogen symptoms. So, and they cause some of the sort of tissues get a little bit less pliable. So people describe things like vaginal discomfort and some dryness, sometimes some skin and hair changes. So they're more the sort of later end. Both sets of symptoms, there are good treatments that we can think about, but we'll come back to that. But that's sort of really laying out how that process happens. The average age for the periods to stop is around 51. And often, as Leslie alluded to, you know, if you see someone with disturbance in their periods and a set of symptoms and they're more than 45, it's going to be menopause until proven otherwise. So we rarely do tests at that stage. There are tests, they're not always very good. And sometimes we use them if something's a little bit unexpected, if someone's a bit younger and we're not really thinking, we're not sure whether it's menopause or not. But the problem is that a normal test doesn't necessarily tell us that it's not menopause, and vice versa. An abnormal test doesn't necessarily tell us that it is. So sometimes we're none the wiser. So we try and steer away from tests if we possibly can. So I'm just trying to move this on, which it's not doing. Didn't want to go to that one next. Sorry, I don't want. Aha. So I just wanted to cover a couple of things about menopause, because I think, you know, sometimes we think it's a bit sort of falling off a cliff. People dread it. They think it's really worrying. I'm getting older. I don't feel myself. And I just wanted to sort of talk about a couple of things. There are some really, really helpful things to do aside from HRT, and HRT definitely has a role for some people. But also there's a lot that we can do around lifestyle, which one helps to manage symptoms. So a lot of the things like the exercise, I've put a picture of yoga up there because actually yoga is something that people find very helpful. Strength building, activity, which helps bone strength. So all these things in physical activity, it's an opportunity to think about, one, can I manage my symptoms better? And two, how am I going to prepare for this next phase of my life, which is, you know, honestly, it's probably almost a half of your life, if not, you know, if we're lucky. So preparing to be healthy is a good thing. And things like cutting down on alcohol, stopping smoking, they're all good health related things, but they also do help. Sleep hygiene, we've touched on sleep problems, trying to have a regular sort of pattern, but also thinking about some of the more psychological symptoms and how to manage those. And there's all sorts of non-HRT ways of dealing with that. And also to think it's a complicated time of life. So hormones are changing, yes, but so are lots of other things. And I think often I see people who come in who have got complicated lives. They're often at the peak of their careers. They're often dealing with some social change at home, you know, either having had children or having not had children, having a relationship or not having a relationship. It's quite a watershed moment. So just to take a moment to think about which of the psychological symptoms that you're experiencing are truly hormonal and which might be, related to a complex life. And I think often it is just a combination of those things. But I'm going to now move on to talking a little bit more about HRT. So I'm having such problems with these slides, sorry. There we go. Okay, so HRT, what is it? So HRT, it works for lots of menopausal type symptoms. And people will choose whether they want to take it or not. And I think what I really want us to move towards is making it available to people who can take it and want it. So it's not to say every woman should manage their menopause with HRT. It's saying that every woman should have the opportunity to do that if that's what they want. And to have their healthcare professional, their doctor or their nurse, recognize that their symptoms may be menopause related and give them that choice. So that's the dream. I really do hope that you will, help us to you know, nudge your GP if you're not getting what you need, like Madhu wasn't, to getting that if that's what you want. So HRT is usually 2 hormones. So estrogen, I've talked about a little bit. Your estrogen levels are going down. So it's no surprise that replacing estrogen is the mainstay of HRT. And so everyone who takes HRT really needs the estrogen. And you can give it in all sorts of different ways. And often that's just a preference, to be honest. So you can give it through the skin, or you can give it through as a tablet. And often we give it through the skin. For people with particular risk factors, we might give it through the skin, and I can go into that in more detail if it's useful. But for many women, taking a tablet, if they prefer it, is perfectly okay. So the pictures I've got up there are just an example. So there's Estrogel, which is a gel which you rub into the skin, and that Everol is a patch that gets stuck on the skin, and that tends to be changed twice a week, where the Estrogel tends to be given every night. So you can see that there are different regimes. They do the same thing. So it really is about a preference. And you'll see that below the estrogen, I've put a picture of a uterus with a cross in it. So if you don't have a uterus, so commonly that's because you've had a hysterectomy, you only need estrogen, and it makes it very, very simple. However, most people probably do still have a uterus, and they therefore need to take a second hormone, which is a progestogen or progesterone, and that protects the lining of the uterus from the effects of the estrogen. So we have to balance it up with the second hormone. And again, there's lots of different ways that you can take that hormone. You can take it through the skin. So that Everol Conti is a patch that's combined. So it brings both hormones together. The Utrogestan, you'll see there, is a tablet. And you see at the end, I've put the Mirena, which is a small intrauterine device, like an IUD or an IUS that you might have used for contraception. It has the progestogen in the stem. So it's very, very good way of taking the progestogen and just having it in the place that it's needed, rather than taking it as a tablet. So again, preference, these things don't matter, but they need to suit you. And sometimes we have to fiddle around a bit to get the combination that works best for someone. And that's very individualized. So there's no one size fits all, a bit like there's no one size fits all for symptoms. So just a last slide before we go on to sort of more questions. I just wanted to talk a little bit about risk, because HRT's had a bit of a journey in terms of people worrying about it and people thinking about risk. And I think that what people need is a really, really good discussion about what their attitude is to risk and where they want to place themselves. And to be honest, HRT, we know now that it's a really, really low risk treatment for almost all women. And the one outstanding thing that people do think about a bit more is about the risk of breast cancer. So I'm just going to very quickly go through this slide. I'm not going to go through it in too much detail, but just to sort of understand a little bit about what the breast cancer risk is. So if you had 1,000 women between 50 and 60 who weren't on HRT for 5 years, about 23 of them would be diagnosed with breast cancer. And if you had 1,000 women who were on HRT, 4 more of them, about 27 in every 1,000, would be diagnosed with a breast cancer. So we know there's no increase in the risk of dying from breast cancer, but we do see a few more diagnoses. And of course, the take home is make sure you go for your mammogram when you're 50. Do keep up with all the preventative healthcare, like the cervical screens and so forth. Before I move off this slide, I just wanted to also show you that risk of breast cancer is related to all sorts of different things. So HRT, yes, one thing, but if you look, you know, there's 5 additional women who drink more than 2 units of alcohol a day, for example. Smoking is an increase in risk. Being overweight is an increase in risk. So all I'm saying is that it's really important that you, when you think about, is this a risk for me, that you balance it up against all the other factors that are going on. I'm going to stop there because that's a lot of information at you, and much rather do something more interactive now to answer what you really want to know.
So thank you, Sue. That's really helpful. And I'm really glad that you used that last slide, because I think one of the myths that we've got to bust is that HRT gives you breast cancer. And I would also add to your lovely slide that when we had the last MHRA alert about breast cancer, Janice Reimer and I wrote a letter to the BMJ saying, well, complaining that actually this wasn't actually pointing out to women that if there were, as you said, 4 more cases of breast cancer, but there weren't 4 more deaths. And of course, the HRT benefited women in their cardiovascular, in their osteoporosis and frailty. Some data has suggested it also may help with dementia. So it wasn't actually changing their lifespan, but it was actually, but withholding it could actually change their lifespan quite adversely. And I think most women still don't appreciate that the biggest trigger for breast cancer is obesity. And I think that's something that we do as healthcare professionals have to keep on talking about, even if it does get us bad press and a few enemies. But it really is important because it's by far the biggest trigger there, isn't it? Now, would you like to focus on some other myths? Or perhaps, I tell you what, well, let's talk about the women first who are told that they can't have HRT, because I meet so many women who say, oh, but my doctor said I couldn't have it. So what are the absolute no-nos for HRT? There aren't that many, are there?
There really aren't very many. And I would even go as far as to say, I don't like an absolute no-no. So there are some women for whom it makes me, and very, very few, that makes me feel a little anxious. But again, going back to your point, Leslie, about, you know, if you're so debilitated by symptoms that you're unable to function, and note in the breast cancer risk about the reduced risk of breast cancer with physical activity. So you are really going to accumulate other risks. So the first thing I would say about, are there women who can't? I would say every decision is based on an individualized discussion, and it is about weighing up risks and benefits. So I suppose the big thing, again, you know, to go back to the breast cancer idea, is that if a woman has had breast cancer, I feel I really try to encourage her away from HRT, and almost never would I prescribe HRT for her. Having said that, I do have some women who've had breast cancer who are on HRT, and that's after a very, very, very careful discussion about and people who feel that they cannot live in the way that they are, and probably are going to go and take it anyway, regardless of what we say. So I think we have to build trust with our patients, say, on balance, I do not recommend this for you because it's likely to increase your risk of a recurrence, because we know estrogen feeds breast cancer. There are alternatives to HRT, and, you know, kind of shaping what you give people according to what their main symptoms are. So, for example, if someone comes with hot flushes, one can think of all sorts of alternatives that people have found helpful. If someone comes with primarily anxiety symptoms, to think about what else might we use for anxiety. So we would definitely explore those things first. And I would say overall, if I am worried about risk, we're always thinking about the lowest possible dose of estrogen for the shortest possible time. So none of these things are absolute, but I think we have to be really, really, really cautious in someone who's had a breast cancer, because we know directly estrogen is a, you know, a factor that supports growth of breast cancers.
And of course, that's how we were trained. But I'm just going to put the breast cancer in sufferer and I've had several episodes actually, and I've got a fantastic oncologist who says, oh goodness, I'm not going to stop you taking your transdermal HRT and having your Mirena, Leslie, because I know that you're going to be miserable. And there are other things that can get you. So I'm quite active, etc. So I'm quite slim. So I think that I've worked out that for me, the benefit I get really outweighs the problems. But I agree that's difficult. And now the other
and
thing,
that's sorry, but that is absolutely what we should be doing, is giving people, you know, people being able to make adult decisions based on as much as we know.
Absolutely. And then the other issue that I often get asked about, or from other clinicians, they say, oh, well, I can't give her any HRT because she's had a thrombosis, or she's got an increased risk of a deep vein thrombosis or whatever. So I'd be interested in your thoughts on that, because of course the transdermal estrogens don't increase the risks, do they? And so that's a very important point to come back on if somebody says that to you, meaning to be protective, but I'm sure that in Madhu's case, she felt that someone was withholding something from her.
It's true. And I think, you know, people are quite nervous about HRT because of the history. And actually, we know that transdermal, so estrogen through the skin, doesn't increase your risk of thrombosis. So even if you've actually had a pulmonary embolus or, you know, a different type of thrombosis, so you might have had a heart attack or a stroke, that shouldn't stop you getting HRT. So if you are able to have a sort of conversation with your doctor about, I mean, you shouldn't take tablets, because you remember I said at the beginning, there's some people that we don't really like them being on tablets so much as having it through the skin for this very reason. So if you had a higher risk of a thrombosis, and sometimes when people are a bit more overweight, their risk of having a thrombosis is higher. So I tend to steer them towards the sort of transdermal products, which are, you know, which people generally quite like anyway. But I think that I can't really think of any particular instance where it would be an absolute no. I think, you know, it's interesting when you start thinking about, so commonly we give HRT to women between their 50 and 60. When we look beyond that, again, it's an individual decision. And as you get older, your risk of all sorts of things gets more. And, you know, we just don't know, do we? The important thing is just keeping healthy. Does HRT increase your risk when you get older? Maybe a tiny bit when you get beyond 60, but probably if it's less than other things that you're going to be doing, like not exercising, getting a bit overweight, maybe drinking a bit more than you know that you should. Those kinds of things are much more likely to have a bad impact on your future health. So I think, again, you know, often GPs aren't so happy to prescribe it for women over 60, but it's not to say that you can't have it. It's more to say maybe it's a bit more of a detailed discussion.
Yes, thank you very much for that. And I just want to answer a couple of questions about complication, or rather reasons why you shouldn't go on to HRT. And there's one lady who's asked that she hasn't had a hysterectomy, but she's only on HRT, estrogen HRT, following a consultant's advice that as long as you have 4 periods per year, you have enough natural progesterone to protect the lining of the womb. So I would say I don't think you've been given the right advice there, that unopposed estrogen is not going to be something that you should continue for any length of time at all. And one of the easiest things, of course, would be to have a Mirena fitted, wouldn't it? Because they last for 5 years and you don't have to take anything then.
Yeah, and you know, that worries me slightly, because we know that does increase your risk of a what we call an endometrial cancer, which is the lining of the uterus. So it's quite easy to take a progestogen, and as Leslie says, you know, the Mirena is kind of probably the easiest once it's in. The other thing I would say, that there are some progestogens like the Utrogestan that you would have seen my picture of, which has a bit of a sedative effect. So sometimes people find that bit of the HRT actually really useful because it helps with their sleep patterns. So it's not all bad, the progestogen. It's either not helpful or it is a little bit helpful, but rarely does it cause side effects. And we can always tweak the progestogen if you don't like the one that you've been put on, because there's lots of choices.
Yes, and I think I expect the Hawkeyes in our audience will have picked up as well, is that the combined HRT, so the ones with progestogen, may increase the risks of breast cancer slightly more, not breast cancer deaths, but the incidence of early breast cancers, but that in fact estrogen alone doesn't. So that's an interesting point as well for everyone to remember. And as you say, Sue, if you have a transdermal estrogen, minimum risk, and if you have a Mirena, minimum absorption of the systemic progesterone. So I think that's the recipe to success for many women, if they're happy with that. So that's good. Now we've got quite a few questions about testosterone. So whilst you're thinking about what we need to do, because some women are saying to us, look, well, why is it that it's only available privately? Well, the answer to that is quite simple. It doesn't have a license for hormone replacement therapy. So if I was to give Madhu a prescription for testosterone, I would have to write down prescribed outside recommended guidelines with patients' consent and understanding, or with patients, fully appreciating that. So, comments about testosterone. Madhu, perhaps I should just ask you: do you have testosterone as well?
I did have testosterone. That was when I went to the menopause clinic. They actually prescribed it because I was having problems with my libido. And also, I think it was the focusing to help focusing outside of me. And then what happened was the conversation eventually, because I was with the menopause clinic for a year or so, the conversation sort of died down regarding testosterone. Then I didn't go back to my GP. But what happened was, where I was applying the testosterone, basically I was getting a lot more hair in that area, and I just didn't like it. So I decided, actually, I'm just not going to take it now. But one thing that I've learned about HRT is that, as Dr. Sue Mann mentioned, the fact is HRT can work on certain symptoms, but there's other symptoms that you have to work alongside with. It's not that thing that's going to fix everything. There's certain things that you actually have to work on yourself. And the other thing about HRT, it's not going to work straight away. You might go through a different trial and errors of what HRT is going to work for you.
Yes.
So I think it's really important for women to realize that they need to track what's still happening to them when they are taking HRT, so they can be aware of what's working and what's not working.
Exactly. I think that's a really good point. And the other thing I would like to emphasize before I ask Sue about what she tends to do about testosterone prescriptions, is that I think it's important to emphasize as well. I'm seeing a lot of women who are getting increasingly higher and higher dosages of HRT. And I think that is something that worries me as well. So women who are taking higher and higher estrogen dosages, and I'm not sure that their womb lining is protected sufficiently when they go on to very high dose estrogen. But Sue, what would you say about testosterone and then the higher doses of estrogen?
Yeah, I'm glad you raised that point, because that also worries me, and we can come back to that. And also, I just wanted to pick up on something Madhu said about, I think what quite often I say to my patients, that because sometimes it's a bit confusing with all the symptoms and it's really hard to see wood for trees. And there's something called the green climacteric scale, green with an E on the end. And I tend to get people to print that off, and every time they make a change in treatment, to give it 6 weeks and then tick off, it's a sort of symptom checker, and then have a look and say, what's the lowest possible dose of estrogen to make me feel as good as I can feel? And when does it going up a dose not make any difference at all? And then you can kind of titrate it yourself. You don't need someone else to do that. So that's the first thing. Second thing to say about testosterone. So let's talk about libido, because I think that's a really important thing. And it's one of the commonest things that people come with. Not forgetting that libido is complicated. Relationships might have been going on for a very long time. There might be some other symptoms going on, like, a bit of dryness around the vulva and the vagina, which might make sex uncomfortable, which therefore might make you a bit uninclined to go there. So, you might be feeling a bit anxious or a bit low. That might affect your libido. So really trying to think about what are the other reasons that I might have a low libido. And also, if I treat my main symptoms of menopause with HRT, get that really, really right, will that make my libido better? And quite often it does, to be honest. And quite often a bit of estrogen actually has a great impact. But for some people, libido remains as the thing that they just can't get sorted. And often the relationship is great, the HRT is great, but they just, the idea of having sex is really not on their cards, and it's affecting their relationship. And then I think testosterone definitely does have a role. As Leslie mentioned, it's off license, so we have to prescribe in a way that is, we believe in terms of our clinical judgment, that this is, there's enough evidence to say this is a good treatment. So we're using the male testosterone here. There are other products in Australia. Unfortunately, they're not here yet, but they will come. And basically, it's another through the skin treatment. So you take a tiny, tiny blob of testosterone. There are various different types. You'll probably have seen Testim, Testogel, Tostran. You know, it really depends on your local pharmacist and what they have in stock. So it's worth checking that out with your GP. And we tend to measure people's levels to begin with, because we don't want them to be out of range when we're treating. So we take a baseline blood level. That's when we do tests. We'll give them some testosterone to take every day, like a pea-sized blob. And then we'll check that they're not their testosterone levels aren't through the roof. And people can find that really effective. I think there's been a lot of talk about what else testosterone does, and people say, oh, you know, I'm a bit low in energy, give me some testosterone. And I don't really think we have enough evidence to say that testosterone is going to improve your energy levels, but I do think we do for libido. So that's something to keep in the back pocket. If you've done everything else and that's still a thing, then that's something to go and have a conversation about.
Yes, but it's interesting. I was talking to an endocrinologist the other day who was explaining to me that when you look after men, which of course I don't, that if they have low testosterone levels, even if they're about 90 years old, the endocrinologist has been trained to get them to take extra testosterone. And she was also sharing with me, and I suppose she's about 20 years younger than I am, but she was sharing with me that when she did her endocrinology training, that the menopause wasn't part of the schedule. I mean, I just thought that was so extraordinary. 51% of the population have a menopause. Anyway, I mustn't rabbit on that.
Could I just say something about the testosterone just very quickly? Normally you get a testosterone, the prescription prescribed from either the menopause clinic or privately if you go to see someone. Could a GP prescribe testosterone?
So that's such a good question, Madhu, because, you know, because it's off license, what that means is that the doctor who is prescribing it has to feel confident that they're happy that they know about the product they're prescribing, and they feel happy to counsel you and pick up on any side effects. Some GPs don't feel confident, and I think that's okay, as long as they then put you into a direction where someone else will do it. But I have some GPs who say they don't want to do it, and I sort of think, well, okay. You know, I think we can train GPs hopefully to take that responsibility, but at the end of the day, you have to be able to justify what you do, and if you don't feel prepared to do that, then you'll have to look elsewhere.
So I think there are several questions here as well about deep vein thrombosis and being treated for DVT, and questions that were also submitted prior to the webinar today. So I think we should have a little look at that. So I'm not surprised that you were taken off it by your GP or your physician, hematologist, when you had the DVT. But Sue, what do you think about women now who are on apixaban and rivaroxaban? You know, so these are the new generation anticoagulants. So how would you feel about them? Because you could argue that they are being treated, aren't they, for their stickiness. So is transdermal estrogen, not oral, but is transdermal estrogen a complete no-no for those women?
No, I think transdermal products really aren't, even if you've got a current DVT or you've had a PE, important that you know, it shouldn't, because what transdermal products do is they bypass the liver. And the important thing in deep vein thrombosis or other forms of clots is the liver clotting factors. So by bypassing the liver, you make it safe. And there's really good evidence that it's fine. The thing about being on an anticoagulant, which thins the blood, is that, you know, if you have bleeding problems as a result of your HRT, and sometimes you go onto HRT and you do have some bleeding, and then you might have slightly heavier bleeding because you've got something that's affecting your clotting. But apart from that, I would say, I think, you know, that needs specialist input, though. So it would be unlikely that your GP would agree to prescribe, because I think that they rightly don't feel so confident about that. And hopefully you should have a local menopause service where you can be referred. And Leslie and I have been working hard to try and get women's health hubs up and running. And that is a sort of ideal thing that ultimately will be treated in a women's health hub.
because I see some women who've been taken off their HRT because of a blood clot, and yet they're being treated. I mean, you rightly said, I've got a woman at the moment, a wonderful lady, who's absolutely debilitated and all this. Put her in. She's got some very strange and very rare chest disease, but she'd been taken off her HRT because she'd had a tiny clot. And yet she was on a Pixaban or rivaroxaban, and she was pouring. I mean, she dropped her hemoglobin. I said, "Look, stop it, stop it." You know, we must just put her back on some HRT and put a Mirena coil in, and we'll get this under control, or give her high dose Provera for a bit. So there's lots of things we can tweak. So as Sue rightly said right at the beginning, there's very rarely a complete contraindication. If you can go to see a specialist with expertise in how to get around those problems, and give you safe HRT, it is often a very good one. Now, there's also a lot of questions about family histories of breast cancer, and I can't answer them too specifically without knowing more about the particular individuals. But I would say that if there's a family history of breast cancer and you have been screened genetically for the genotypes that predispose you to breast cancer, well, those you will have to speak to an individual oncologist about your risks. And of course, as you know, some women then opt to have a prophylactic mastectomy, for example, if they're BRCA positive. But some of the other genetic things are not. But if you've got a family history, but you don't have those gene mutations, then I don't think there's any reason why you shouldn't have HRT, and there's actually, the gene mutations are relatively rare, aren't they, Sue? They're very highly penetrant. So if you have them, they tend to really rack up your risk factors, but they're not that common. And having one or two members of your family, for example, my mother and grandmother died of breast cancer, but I don't have the gene. So another reason why I stay on my HRT. But Sue, are there any other points that you'd like to ask about that, comment about that?
Yeah, I mean, I think it's a slightly complicated one, isn't it? Because, and I think often, people are in touch with the family clinic and having a liaising with the menopause specialist and the family clinic to try and quantify for you the risk. It's a very hard thing to do. But in the end, if you have a genetic risk, probably HRT is going to increase that a little bit, and we don't know whether that adds or whether it multiplies. So it will be about saying, well, here's one risk, here's another one. Make sure you exercise well, make sure that your weight is kind of as good as it can be. That's going to put your risk down, and then make an informed judgment. But the problem is people often want numbers, like 1 in what I will get a breast cancer, and it's not possible to do. So we end up being a bit of a sort of fudge. Well, it probably will increase your risk slightly, or more than slightly. So having a conversation with the breast specialist is also helpful for us sometimes. And we often, communicate together and help people to make their decision. But in the end, it is, I think, your decision, not our decision. Our job is to try and give you some information with which you can make a decision. So I think that's the important thing.
Yes. So one quick fire question though. Lots of questions about HRT causing weight gain. Am I being unfair if I say, well, you won't put on weight if you don't increase your calories or reduce your exercise? I mean, it's a balance, isn't it? Sue?
Yes, and also, unfortunately, weight distribution changes as we get older, and people do find it, they do, as a population, there is a general increase in weight. So weight sort of generally goes up. You have to work harder to keep it off. Probably eating is a bit less forgiving than it used to be. So often people think, oh, I put on weight with my HRT, but probably put on weight because you got older, maybe got a bit more inactive, maybe more busy. So really be honest and think, what else is going on? Yes, I'm getting older. That is a thing. But the rest is just really trying to work hard at it. And I don't think blaming HRT can make you more active, because it can make you more energetic, and then you can lose a bit of weight. So it works both ways, and it isn't really the HRT, no evidence.
Now, in less than 1 minute, I'm going to have to finish this webinar. We've been inundated with questions, and I've got to obey rules and finish in just a moment now. But there's been several questions about, is there a time limit? And one lady was saying that she's been told that when this Mirena wears out in 5 years, that's the end, she can't have any more. My personal view is that I don't think that there's any data to suggest that that is the case. And I can personally say that no one's taking me off mine because I'd rather not have all those other things. And the other thing I just wanted to address, because I was so pleased to see that we've got some gentlemen on the call, because I'm very keen on male allyship when we're talking about women's health. And so yes to Adam Robinson, what can we do to support our pre, peri and menopausal and postmenopausal colleagues in the workplace? Fantastic question. And I would say, please go onto the Wellbeing of Women website and get your company or your organization to sign up to the Menopause Workplace Pledge. You'll join a group of over 3,000 people, and there are all sorts of resources on the Wellbeing of Women website to help you and help you to be the very best employer. And as I say, my mission in life is to get the NHS to be the best employer for menopausal women, because so many of 80% of the employees are women, and we really do need to look after them, and we can't afford to lose them. So I have to finish because I'm going to get into big trouble. Lots of people saying thank you, wonderful, wonderful webinar, wonderful information. Yes, we will give you all the recording, and yes, and we'll invite our specialists to come again, because I'm sure we could go on for a lot longer. So masses and masses and masses and masses and masses of thank you. So to Dr. Sue Mann and to Madhu, I'm absolutely thrilled that you've been here. Thank you so much for your wisdom and your generosity in sharing your experience and your personal views about all this. It's been a real pleasure. And thank you to Wellbeing of Women for hosting these webinars, and to our sponsors for today. So come and join us. Wellbeing of Women is always looking for more volunteers and more people to do all sorts of wonderful things for women. So thank you, and I'm going to sign off now. Bye-bye.